All right, so chapter 24 is going to be trauma overview, and this is going to introduce us to the principles of trauma, which we will look at each chapter more individually with bleeding, with soft tissue injuries, splinting, head injuries, spinal injuries, those types of things. So this is just going to kind of all encompass that. And I'm going to do something a little bit different with this video that I haven't done before previously. I have been breaking the videos up into like 15-minute segments, as you guys know, but I'm going to try to film this video from start to finish, however long that takes, and I'll probably do the rest of the videos moving forward from there. So if you need to pause, take a break, walk away, whatever you need to do, then pause the video and come back to it rather than me breaking it up into separate sections. All right. So let's get started with chapter 24. So traumatic emergencies occur as a result of physical forces applied to the body, whereas medical emergencies occur from an illness or condition not caused by that outside force. And so obviously we know that's the difference between a traumatic injury or a mechanism of injury and a nature of illness type of call. Now, remember, a patient can be suffering from both, so we don't want to get tunnel vision on that, and we want to have an index of suspicion, which is your awareness for potentially serious unseen injuries. And so what it means to have a high index of suspicion would be you're looking at the mechanism of injury. So I always say a motorcycle crash. Let's say the patient was ejected off of their motorcycle, but they're walking around when you get on scene. Well, just because they're walking around doesn't necessarily mean that there are not potentially dangerous unseen injuries there that we definitely need to be concerned about. And so your awareness of that, your assessment of that, your need to remember that there are things that could be going on inside, that's your index of suspicion. So traumatic injury occurs when the body's tissues are exposed to energy levels beyond their tolerance, and the mechanism of injury describes the forces that were acting on the body that caused the injury. So how was the person injured? Was it blunt trauma? Was it penetrating trauma? And then, were they traveling in a vehicle at 60 miles per hour? Because that energy has got to transfer, and we're going to look at that a little bit more closely here. So there are three concepts of energy. That's potential energy, kinetic energy, and the energy of work. Work is the force acting over a distance. And so these forces that bend, pull, or compress tissues beyond their inherent limits result in injury. So that means I could compress your arm and it, maybe cause you a little discomfort, but your body can still tolerate it. Once you go past their limits, that's where the injury is going to occur. That's where tissue is going to break. That's where bones are going to break. That's where we start talking about potential damage. So kinetic energy is the energy of a moving object. So that the way that you would figure out kinetic energy is half the mass times velocity squared. Now, I'm going to tell you, I'm never going to ask you to determine kinetic energy on a test, and they are never going to require you to do this in the field. But you do need to know what it is. And you also want to be familiar with those terms, because even though I'm not going to ask you to do a formula for this, they definitely you're going to see these terms again on one of your Blackboard quizzes. And that's about the extent of where we'll go with these terms of energy. Potential energy is the product of mass, force of gravity, and height, and this is usually associated with falling objects. So these are why we ask questions where a patient has fallen that are asking like, how far did you fall? What was the height? What type of surface did they fall onto? How heavy is the patient? What part of the body struck the ground first? And those are the reasons for asking those types of questions. So different mechanisms of injury will produce many different types of injuries, and we know the difference between non-significant and significant. So just giving you a few examples of those. Non-significant injuries, remember, these can be injuries to an isolated body part or a fall without a loss of consciousness. And significant injuries, just to name a few, are when you have an injury to more than one body system, falls from great heights, or potentially vehicle crashes as well. Now, blunt and penetrating trauma, these are the two terms that we are going to hear over and over again, but there's a lot of different things that can cause each one. So blunt trauma is the result of force to the body that causes injury without penetrating the soft tissue. So thinking about being struck with a baseball bat, hitting your chest on the steering wheel of a car, those are blunt types of trauma. Penetrating trauma causes injury by objects that primarily pierce and penetrate the surface of the body. So thinking about shootings, stabbings, and that, could be an impaled object like a fence post or a piece of glass, but anything that penetrated the body. So blunt trauma results from objects making contact with the body, like we said, and motor vehicle accidents and falls are some of the most common types here. You want to be alert for skin discoloration or bruising, swelling, and pain. And we should maintain a high index of suspicion for hidden injuries, particularly if that blunt trauma happened to the head, to the chest, to the abdomen, areas where we know there could be a lot of potential serious damage. So vehicle crashes, it actually consists of 3 collisions, and you're going to see this information again. You're going to see it on test questions. We're going to talk about it again, so make sure you understand what this means. It is the car against another car, a tree, or an object, all right? That's the first crash. So what's happening here is you're driving down the road and you strike an object, whether it's another car, whether it's a fence post, a telephone pole, a tree, whatever it is. That's the first crash. And you can often determine the mechanism of injury simply by looking at the vehicle. All right, if you take a look at this vehicle, it's difficult to see the inside patient compartment, which is really important to document in your patient care report. But just based off of this alone, you can tell that there is significant damage to the front end of that vehicle. And also taking a look at the windshield, it looks like, the windshield is broken, but is it completely broken? Is there any spidering where the patient may have hit their head? And then with that motor being crushed like that, it was probably pushed onto the patient. And so that intrusion into the patient compartment is a definite factor when we're considering how significant is the mechanism of injury. This is another example here. So the second part of the crash is the passenger against the vehicle's interior. And so common passenger injuries include lower extremity fractures, flail chest, and head trauma. So again, looking at this vehicle, this patient would have most definitely needed to go to a trauma center, all right? So what we can tell right here is that the patient could not get out. They had to extricate the patient by cutting that post there on the vehicle. You see it flayed open. Their seat was broken and displaced. They have intrusion into the compartment. That motor dashboard is pushed up onto the patient. They had airbag deployment, but it looks like the steering wheel is honestly completely gone just by glancing at this. This is a lot of damage, all right? So we're going to start to consider how much of that, how fast was the patient going, because that's where we get into this 3 part of the crashes. If your vehicle is traveling 60 miles per hour and you strike an object, it comes to a sudden stop. But now that energy has to be transferred somewhere, so it transfers to your body, and now your body is traveling 60 miles per hour until something stops it, like a seatbelt or your steering wheel. And then once it comes to a stop, your organs are still traveling 60 miles per hour. So that's going to be the third portion of the crash, which is the passenger's internal organs against the solid structures of the body. All right. And so this could actually be what is the most life-threatening. And what you see here in this picture with this guy hitting his head on the windshield, and it's showing injury to both the front and the rear portion of the brain. That's a coup contra coup injury, which we'll look a little bit more at with head injuries when we get into that. But essentially the brain is being moved forward and then also moved back. So you actually have damage to 2 areas. So looking at some different types of vehicle crashes, you have the frontal crash. So you want to evaluate the supplemental restraint system. We're going to determine whether the patient was wearing a seatbelt, whether it was adequately secured, whether there was airbag deployment. These are some of the most effective things in preventing that second collision from inside of the motor vehicle, but they can be just as dangerous. Airbags and seatbelts certainly have their place for safety, but think about injuries that can come from those things as well. This is one of those examples here. You see this patient had their seatbelt on, but you see that abrasion to the skin from the seatbelt. So we're also looking to see, is there any type of internal organ damage there, because it's probably just some bruising up around the chest, which is well protected with bones, but in the abdomen that's less protected. Is there any potential for internal injuries there? Non-deployed airbags can be a safety concern during extrication because they can go off during that point. So again, that's a safety concern for us as providers when we're evaluating the vehicle. Again, as we said, supplemental restraint systems can definitely cause harm whether they are used properly or improperly. And so going back to airbags, usually airbags traveling around 200 miles per hour when they come out. And so there have been plenty of cases where children were improperly sitting in the front seat, weren't tall enough to be sitting in the front seat, weren't over 12 years old. And when that airbag deployed, it caused some serious damage to their face, to their head, even in some cases, very serious cases, decapitation. And so really want to make sure that we're using things the way that they are meant to. All right. Looking at rear end crashes, these are known to cause whiplash type injuries. So as the body is propelled forward, the head and the neck are left behind. And you also have acceleration type injury to the brain. Again, as we mentioned previously, it could be coup contra coup, where you have it hitting the front and then popping back on the back if the back of the head were to hit the headrest. But definitely something to be concerned. So, well, this might not be a serious injury as far as broken bones. It can definitely cause injury to the head, the neck, and the spine. Lateral crashes, which are side impacts or T-bones, the vehicle is usually struck above the center of gravity and rocks away from the side of impact, can cause it to turn over. It can also result in whiplash, particularly to the passengers, as the body essentially moves the same way that you would in a rear end collision, but over to the side. So where the patient was struck at, it can cause chest and abdomen injuries on the side of impact, pelvis fractures, lower extremity fractures, and organ damage, things like that. So lateral crashes are definitely very significant. Rollover and rotational crashes, two separate things. A rollover crash is usually where the actual vehicle rolls completely over, and this is prone to large trucks and SUVs, especially ambulances. If there are very few ambulance accidents that there is not a subsequent rollover. So be very careful when you're out there on the road. The injuries are going to depend on whether the passenger was restrained. You could have ejection or partial ejection, which would be the most common life-threatening event. And I will say that I have seen it happen both ways. I have seen a patient who was not restrained, who was ejected, where that's the only thing that saved their life, because the vehicle was just completely demolished after it continued to roll and roll and roll. But I have also seen times where a patient, was ejected, and that was fatal for them, where if they would have had their seatbelt on, it would not have had the same outcome. So again, the good and the bad with everything. Now, rotational crashes are very similar to rollovers conceptually, but instead of rolling over, they're spinning. So thinking about vehicles spinning out on the highway, and eventually they're going to come to a stop somewhere, but they might strike other objects and vehicles in the meantime. So potential for a lot of damage. Looking at car versus pedestrian, these injuries are often very graphic and apparent. You don't have a lot of protection from that. They can also be very serious unseen injuries. So going back to head injuries, abdominal injuries, things that we can't outwardly see. We need to determine the vehicle speed and whether the patient was thrown through the air. So as we mentioned in the pediatric chapter, usually there's a trajectory pattern, and it depends on the size of the patient and also the size of the vehicle as to whether the patient went up and over or down and under the vehicle. So again, we're looking to see, is there any structural damage on the vehicle, because that makes a difference as well. You can kind of tell how hard was the impact. Car versus bicycle, you want to evaluate this just like a car versus pedestrian collision. So you're looking at the damage and the position of the bicycle, looking at the helmet for any damage, and making sure that, of course, we are maintaining our spinal stabilization. Car versus motorcycle, there should have some protection from their helmet, and also leather or abrasion resistant clothing and boots if they're wearing it. Oftentimes with people who ride motorcycles, there's an old rule of thumb: dress for the slide, not for the ride. So even when it's hot outside, you should be wearing the appropriate protection there, but not everyone does. So when they're not, that's where you can look for a lot more potential soft tissue injuries, which we'll get into in a few. So when we're looking at this thing, we're looking for deformity of the motorcycle, the side with the most damage, the distance of skid in the road, the extent and location of deformity in the helmet. And just like with regular car crashes, there are several different types of motorcycle crashes as well. So you could have a head-on crash. Motorcycle strikes another object and stops the forward motion, and the rider continues forward motion. And so that goes back to the transfer of energy that we talked about. So if you were going 80 miles an hour on your motorcycle and it comes to a stop on a fence or whatever is stopping it, now the passenger is going to be traveling at 80 miles an hour until it hits something to stop it. So that's could be potential for a lot of damage. Angular crashes, where the motorcycle strikes an object at an angle so that the rider sustains direct crushing injuries to the lower extremity. Ejection, where the rider will travel at high speed until stopped by a stationary object, another vehicle, or road drag. Looking for a lot of severe abrasions here. And then a controlled crash, which is a technique used to separate the rider from the body of the motorcycle. So thinking about laying the bike down to avoid a more potentially serious crash. And so that's something that you might see as well. So we're looking at falls. Here we've got injury potential. That's going to depend on the height from which the patient fell. So you're always considering the patient's height. You're thinking about how high was their head from the ground. Okay, so if you're 6 feet tall and you're standing at the very top of a 6-foot ladder and you fall, you actually are falling 12 feet. So you want to take that into consideration. If I'm 6 foot tall and I'm standing on a 2-foot step stool, then I fell 8 feet. All right, so just taking that into consideration there. Usually twice a person's height or greater is going to be really significant. So again, 6 feet tall, falling from the top of a 6-foot ladder, that would be significant. Internal injuries are going to pose the greatest threat here. The patients who land on their feet may have less severe internal injuries because the legs will absorb a lot of the fall. But as you see right here in this picture, it's going to transfer that energy up. And so you're looking at the potential for broken bones from the heels, the feet, the legs, all the way up to the hip and potentially the spine. So it can still be potentially serious. So we want to take all of these things into account. The height of the fall, the type of surface struck, because it's a lot different if you fall onto grass than concrete, and the part of the body that hit first, so that we can kind of look at the trajectory and the energy displacement. Was it the head? Was it your feet? Was it your butt? What hit the ground first? Looking at penetrating trauma, this may be caused accidentally by impalement or intentionally by a weapon. So what you see here, difficult to kind of tell what this is, if this is a knife that has some screws sticking out of it, but that object is impaled. And so we're going to talk about management of impaled objects, but if something is in place like this, there are only 2 times that we should be removing any impaled object, and that is number 1, if it is interfering with airway management, or number 2, if it is preventing CPR. So with where this is located at, if it needed to be removed because we needed to do chest compressions, we could do that, but otherwise we really need to leave it in place and we would stabilize it the best that we could. With low energy penetrations, the injuries are caused by the sharp edges of the object moving through the body. So we're thinking more like glass, knives. These may have been deliberately moved around to cause more damage. So even if they're left in place, there could be still a lot of potential damage in there. The path of the projectile may not be easy to predict either. Bullets can ricochet within the body before exiting, or sometimes they don't exit at all and they become lodged somewhere. The path that projectile takes is called its trajectory, and fragmentation will also increase damage. So we're going to look at some bullets and different ways that shrapnel can actually cause damage on its own if it stays all together, or the bigger that it gets, the more it separates, the more damage it is occurring. This right here, this is showing you how a bullet enters. And it's showing you what cavitation is, which can actually result in serious injury to internal organs. So you see the permanent cavity, which is actually the hole or the trajectory that the bullet is taking, but the shock wave itself causing that temporary cavity can cause damage as well. And I'm going to post a few videos this week for you to look at, and I'll try to just do 2, like maybe a high caliber, low caliber type of bullet, so that you can see what's actually happening with cavitation. The relationship between distance and severity of injury varies depending on the type of weapon. So again, how fast is it going? How large is the weapon? Does it spread apart? So just looking at the different types of damage that can be potentially caused by these. So here are a few examples of things that can be going wrong with your trauma patients, and I'm not going to read through all of these because we're going to look at each individual chapter as we move through them, but essentially they're talking about injuries to the neck, to the chest wall, coming from falls, coming from motor vehicle accidents. So just take a look at this and especially pay attention to that portion that's talking about the index of suspicion. So based off of these potential injuries, what could be happening here? Should you be very cautious of or very suspicious of potentially occurring? So blast injuries, this is going to be like from an explosion. And so what you see here in the picture, it really outlines each one of these. And so I'll go over them really quickly right here, and then we'll move on and take a look at the next couple slides. Right where the blast occurs, that is where you'll actually incur primary blast injuries. And these are injuries that are due to the blast wave itself, so that pressure change. So this is where you're looking for potential injury to eardrums, lungs, hollow organs. That's the type of thing you're looking at with primary blast injury. Now, secondary blast injuries occur if you strike something flying through the air. So thinking about if this was a home, so you got bricks, you got wood, you got glass all flying through the air, that could potentially injure you. The tertiary blast injury comes when you fall, come to rest somewhere. So are you lodged into the ground, concrete, pile of wood, a vehicle, whatever it is, whatever you strike, that's how you get tertiary injuries. And then quaternary is any type of other injuries like burns, crush injuries, toxic inhalations, things like that. You will see this information over and over again. You do need to know what it is, so please make sure you are familiar with that. Again, most patients have some combination of the 4 types of injury, and it's really not your job to determine this is secondary, this is tertiary, but just understanding, how these injuries can be incurred. We said the organs most susceptible to pressure changes during that primary blast, the middle ear, lungs, and GI tract. Pulmonary blast injuries result from the short-range exposure to the detonation explosives. So you could have arterial air embolisms and things we'd be looking for there. Disturbances in vision, changes in behavior or level of consciousness, and any other neurologic signs. Solid organs are relatively protected from that initial shock wave injury, but they could be injured during the secondary missiles or the tertiary side of things when you come to land somewhere. Neurologic injuries and head trauma are the most common causes of death related to blast injuries, and traumatic amputations are common also. So looking at the term multisystem trauma, this involves more than one body system. And so this is just giving you a few examples because it really could be anything, but a few examples would be someone who had trauma to the head and spine, the chest and the abdomen, or the chest and multiple extremities. Different places are going to have different criteria for their trauma protocol. So you want to know what your agency and the surrounding hospitals' policies are going to be as far as trauma alerts. But we're going to talk about some things as we move through the remainder of the chapters that are going to tell us, yes, most likely this would be considered a very serious trauma and need to go to an appropriate facility. So some things to remember when we're talking about golden principles of pre-hospital trauma care. Our main priority is to ensure our safety first, then the safety of our crew and our patient, as with every call that we go to. We want to determine the need for additional personnel or equipment early on, evaluating the mechanism of injury, identifying and managing life threats, and then focusing on patient care from there as far as, secondary assessments, spinal immobilization, shock therapy, which would be like electricity, or whether you are going to be two ways that you can look at that. You can look at it in the mindset of patient has some type of cardiac event where they need electricity to be administered, whether that's with defibrillation or pacing, or if this is going to be your shock management, like keeping the patient warm, applying oxygen, that type of thing. So we want to transport immediately to the appropriate facility. And we're going to talk a little bit more about what the appropriate facility means and the levels of trauma center, but understanding that definitive care requires surgical intervention for trauma patients. So they really don't need an EMT. They don't need a paramedic. They need somebody to get them to the hospital as quickly as possible. There's not too much that we can do. We can help stop the bleeding, but especially further than that, we're talking about internal bleeding or other internal organ damage. They really need a surgeon. So we're trying to limit our time on scene to less than 10 minutes. This should really be load and go, doing that secondary assessment en route to the hospital. And if you're too far out or you've got a really prolonged extrication time from a vehicle or something like that, we could consider air medical transport as well. You might need to consider ALS early on for fluid replacement, for pain management, whatever it is. Not to say that there's not a lot that you can do at the EMT level, but we still might need some additional help. So when a patient has experienced a significant mechanism of injury and is in critical condition, we want to rapidly perform our physical exam. If they have experienced a non-significant mechanism of injury, then remember we would be operating under a medical or a focused assessment and focusing mostly on their chief complaint. Looking at head injuries here, disability and unseen injury to the brain can definitely occur. Bleeding and swelling inside of the skull, often very life-threatening. We should include very frequent neurologic exams, so checking PMS, maybe even a stroke screening, having them, checking to see, asking them questions related to person, place, time, and event. Again, just trying to reevaluate. Looking at the neck and the throat, their main concern here is going to be airway problems. So looking for decap BTLS. There might be swelling that can prevent blood flow to the brain. There might be a penetrating injury that can result in air coming in and creating an air embolism. Could be a crushing injury that has caused damage to the cartilage of the upper airway, like the trachea has been crushed, which would obviously be very detrimental. Injuries to the chest, obviously here we have our heart, lungs, and large blood vessels. Life-threatening injuries can occur here. It could be a broken rib that's hindering breathing. Could be the heart that's bruised. Large vessels could be torn and having some internal bleeding there. Could be a pneumothorax. Could be an open chest wound where you've got air coming in from that area. So as we get to these chapters, these different chapters within the text over the next couple of weeks, we'll be looking at the treatment for each one of these. The abdomen, as we said before, contains a lot of vital organs with little protection from the muscle side of things. And so they have a lot of potential for damage. Solid organs can tear, lacerate, or fracture, leading to a lot of internal bleeding. Hollow organs can rupture and leak their toxic digestive chemicals, which can be potentially dangerous. And then also a lot of large blood vessels running there that can cause very serious unseen bleeding as well. When we're looking at scene time, we said we want to limit our own scene time to less than 10 minutes. It's very important that we are choosing the appropriate transport and the appropriate hospital for the patient. So looking at types of transport, again, around here, we are very fortunate to have a lot of trauma centers close to us, but there's some places that are not. So you might need to utilize air EMS units or critical care transport. So make sure you know what is available in your area and that you're prepared with that. Now this is important, and you're going to see a few test questions that ask about this, talking about the trauma centers and destination selection. So a level 4 facility, we'll just take a look at that and kind of work our way back up. So a level 4 facility provides advanced trauma life support. And so they are trained with nurses and doctors who have some trauma training, but this is more like a local hospital. They're not going to have a trauma surgeon on call. They're not going to be prepared to deal with any type of major life-threatening traumatic injury. And so depending on your protocol, they might be able to stabilize your patient, but most likely you're going to avoid this place with a really severe trauma. The level 3, they have a little bit more. They can provide assessment, resuscitation, emergency care, and stabilization. So again, you could divert there to stabilize the patient if you had to. But where we're really focusing when we say this patient is a trauma, all right, and so not that they had that non-significant mechanism of injury, but they are a significant trauma. they need to go to a level 1 or a level 2 facility. And so really the difference here is that level 2 facility provides initial definitive care for almost everything, right? They've got all kinds of doctors on call. They can do surgery 24 hours a day. This is really where you're going to be transporting to a lot of the time. But then also level 1 facilities that provide every single aspect of trauma care. They have specialists in every single one of these isolated areas. So level 1 or level 2 is really where you want to go when you have significant trauma. All right. So things we want to consider: remaining calm, do your organized assessment, correct any life-threatening injuries, don't do any further harm, call for ALS backup or medical control guidance if you're not sure about where to transport a patient to or what should be done en route to the hospital. So again, this is going to wrap up our trauma overview, and this was just like kind of an introduction to all of these things. We will be talking more about hemorrhage control, soft tissue injuries, and splinting, and then we'll be working our way into the more isolated areas of trauma over the next couple of weeks. So if you guys have any questions about this chapter or any of the others, please feel free to reach out and let me know.